Dr. Tom Lomax, welcome back to the Tokyo Living Podcast.
Thank you for having me. Good to be back.
It's been a little while, but we're happy to have you back on the show. Today we're going to be talking about weight loss medication. 3 years ago, on episode number 34, we talked about GLP-1 agonist medications. And since that time, these medications have been become a lot more popular. I think Ozempic is sort of like a household name now. People understand what it is, and rightly or wrongly, it has been portrayed in the media by celebrity use and things like that. And there's also some newer medications on the market. So I think that it'd be a good chance now to get you back on and have a talk about your experience prescribing these medications over the last few years. We won't go too much into the physiology and the mechanisms of the medication, as we talked about that on episode 34. So if people want to know what these medications do, then go back and have a listen to that episode. I guess maybe just start with talking about your experience with prescribing these drugs and some of the positive adaptations you've seen, and also some of the pitfalls you've seen as well.
Yeah. Thanks very much. So yes, as you said, if you want to know more about the mechanisms, go and listen to the previous episode. But in a nutshell, these medications are appetite suppressants, so you're less hungry on them, and as a result, you lose weight. And they're not stimulants either. I've prescribed a lot of Ozempic and Mounjaro, which is the second medication in the class, which is now kind of becoming more available and more popular. I'd say my experiences have been pretty well, almost entirely positive. Patient feedback is very good. People generally do lose weight on these medications. They're not sort of miracle cure. They don't work in a vacuum. You can't rely on medication alone to lose and then stabilize weight. So they do need to be used in the sort of context of lifestyle changes. But they do make it much easier to lose weight because people just don't feel quite as hungry. So, most of us will have tried to lose weight by restricting how much we eat at some point in our lives. And we know that after a few days, it just gets kind of quite wearing and becomes quite hard work. So it kind of takes the sting out of that, basically. I guess we've prescribed both Ozempic and Mounjaro, mostly driven by patient demand. So people have heard about these medications from friends or from the media. They come in and they ask us to prescribe. So although we are, proactively recommending people consider taking Mounjaro, particularly if they're obese on the basis of their BMI, so if their body mass index is over 30, we will be suggesting that they use weight loss medications if lifestyle alone has failed to, they failed to lose weight on lifestyle alone.
Yeah. Perhaps if we just sidetrack for a bit then and talk a little bit about Mounjaro, that is a newer medication on the market. How does that differ from Ozempic in terms of its mechanism and I guess what's the research in terms of the effectiveness?
Yeah, so Ozempic targets the GLP-1 receptor, and Mounjaro has action against two different GLP receptors, GLP-1 and GLP-2. So it's working through the same mechanism of action. It sort of sends a signal of satiety, so you just feel full sooner and have less of an urge to overeat or to snack. It is slightly more effective. So both the independent trials that just use Mounjaro for weight loss showed slightly better data than Ozempic, but also when I last checked, there was one head-to-head trial. So there has been one comparison where people were randomized and either given Ozempic or Mounjaro, and the Mounjaro treatment group did lose significantly more weight. So we had a lot of issues with supply. 2 years ago, there just wasn't enough to go around, but production's been massively ramped up. So we can now prescribe both Ozempic and Mounjaro without particular issues about obtaining the drugs. Mounjaro is approximately twice as expensive. So for people who are self-funding, and that's quite a lot of people now, because I mean, these medications are not particularly cheap, and insurance companies have really pulled back from them, which is sad, actually, because, I mean, the clinical data is that, people who lose weight have better long-term health outcomes, and particularly people who've got metabolic diseases associated with weight. So this is obese people who have high cholesterol, high blood pressure, obviously particularly type 2 diabetes, which is what these drugs were designed to treat, and conditions like fatty liver or gout. I mean, those conditions will all improve with weight loss. So, I mean, they're not just sort of cosmetic treatments, they're actually improving people's health. But, I mean, I sort of think I saw somewhere in one of the news articles that if everyone who was obese was treated with Ozempic in the US at the current US retail price, it would double the US national expenditure on medication. And the US already spends a lot of money on medication. So we're talking about, potential of tens of billions of dollars. And for that reason, a lot of insurance companies have basically drawn back and have sort of started to exclude GLP-1 and GLP-1/2 drugs from non-diabetics, for people who want them for weight loss, but not for diabetes.
Yeah. Okay. And I guess, have you noticed any population groups that do better with these medications, whether by gender, age, or even BMI? Is it people in the middle range? Is it heavier people?
It's funny, actually, because we had a sort of in-house discussion about this, and my kind of anecdotal experience has been that the very heaviest people have done the least well. So the sort of morbidly obese people that I've treated whose BMI has been over 40 have been the ones who've really struggled. Now, I mean, whether that's because they've got such a lot of weight to lose that, it's so demoralizing if you realize that you're going to be actively trying to lose weight for like 2 years. I mean, that's a very steep hill for some people to climb. So I think in my experience, people who need to lose a lot of weight have been more likely to give up treatment, and not because of side effects, usually just because, they just sort of see that it's going to be such a long time. Whereas people who've got maybe less than 30 kilos to get down to their target weight have tended to do better. Actually, the clinical data doesn't bear that out. So in fact, in drug trials, people who are heavier tend to lose more weight. So what's causing that difference? Why my population's not behaving like the drug trial population, I'm not sure. Maybe part of it is that the very heavy people, I'm tending to sort of drive the prescribing. Like, people come in and see me and their BMI is over 40, so they may weigh like 130, 140, 150 kilos. I'm saying, look, you really need to lose weight. I know you've tried diet and exercise, but I think you should try this. So maybe they're not buying into it as much as people who are actually approaching me and saying, can you help me lose weight? And I think, people who are maybe sort of more marginal benefit, like maybe their BMI is 29, 30, and I'm like, well, you can try this drug if you want, but you could also double down on lifestyle. And they're like, no, I really want to be treated with it. Perhaps they're just intrinsically more motivated. And I've noticed that women tend to do better than men across the board, I'd say. And I think that the clinical data bears that out as well.
Right. Any idea what's driving that?
Not really sure. Whether that comes down to motivation or as a biological difference, I don't think there's a good answer to that now.
Yeah. And is there a limit to a leaner person using these medications? So let's say if someone has a BMI of like low 20s who just wants to get very lean, would you?
I mean, then it's a cosmetic treatment, right? So it's not actively harmful. I mean, let's say someone's weight. I've got a patient whose BMI is 24, so they're not clinically overweight, but their body composition's not great. So that there may be sort of the term you hear bandied around is skinny fat, right? So they're very sort of slender build and they're just carrying a little bit of excess weight. So clinically, there's not a very strong argument for treating those people with GLP-1/2 drugs. So I mean, I've had a few people who've been extremely insistent or have prescribed medication to, because I don't feel there's any harm. It doesn't actively harm people. I'm always very clear that if there's any kind of suggestion of an eating disorder, I won't prescribe GLP-1s. And if people intend to get their BMI sort of below the optimal for their height, so basically, if they want to be treated to a BMI of below 22, I won't prescribe, because I feel that's kind of harmful in that situation. Yeah. But for people who it's basically a sort of cosmetic treatment to lose 5 kilos, but they're within, and they'll stay within the healthy weight range, I don't see any harm in that, but I just regard it as being a cosmetic treatment.
I guess moving on to side effects, what side effects have sort of borne out in the research over the last few years, and what have you seen clinically, and does this sort of match?
I mean, basically it's very consistent. So the most common side effect people get is nausea. A lot of people do feel a bit nauseous, but that's usually relatively transient. It's usually the first 1 or 2 weeks. Activating the GLP-1 pathway delays the speed at which your stomach empties. So people who eat very quickly sometimes vomit if they're taking GLP drugs. But I mean, I basically tell people, look, if you go off and eat a big meal quickly and you throw up, then, that's kind of a signal to you to eat more slowly. And I've never had anyone who's had that more than once.
Right.
Some people get constipated. Some people get quite badly constipated. So we tend to, we try to get people to look at their diet, to encourage people to have like a high fiber diet and stay well hydrated. So people who eat a sort of energy dense processed diet and just reduce the volume of food they take, they do get quite badly constipated. We can give medication for that, but we always want to optimize diet first if people are constipated. And that tends to be a more persistent side effect.
Yeah, okay. Do you find that people lose weight too quickly? Is there a point at which the weight loss is too rapid?
Some people do lose weight too quickly, and it's quite important to define what you mean by that. So, I mean, mostly if people feel they're on an effective treatment that's helping them lose weight, they generally want to lose weight, get to their target weight as quickly as they can. So I generally find myself trying to get people to lose weight in a slow, controlled manner. And I'm typically suggesting people target sort of 2 to 3 kilos weight loss per month. Right. So, I mean, that means if someone has to lose 50 kilos, it's going to take a long time, right? I mean, it's going to take them possibly up to 2 years. So they need to sort of have a sustained approach. They need to look at their diet in detail. They need to be physically active. So all the drug trials that showed that these drugs help people lose weight, screen people and had people doing, I think the sort of minimum exercise was like brisk walking for 30 minutes, 5 days a week. But for that and other reasons, I very much push people to adopt a more physically active lifestyle, and to think about other things like strength training to minimize lean weight loss, because again, you see this more and more in the media now. Particularly abrupt weight loss is associated with loss of lean weight. So if people drop, 20, 30 kilos in 3 months, they lose a lot of muscle mass. So, they're coming in, they've got sarcopenia. Some of the recent research suggests that abrupt weight loss, particularly over a longer period of time, is associated with loss of bone density as well. So people are at risk of osteopenia. So for women, you've got to sort of make sure that women aren't losing weight to the point where they stop menstruating if they're premenopausal, because then obviously they've got the consequences of weight loss, of like sort of persistent energy deficit on their muscle and bone density. On top of that, you've got the hormonal effects of their hormonal axis shutting down. So those women are definitely at higher risk of osteopenia, osteoporosis. So the way we mitigate that is make sure they don't lose weight too quickly, make sure they maintain good levels of physical activity as well.
Yeah. On that first point, so making sure they don't lose weight too quickly, are you having people weigh themselves on what sort of frequency of basis, and how do you go about it?
I mean, I think if, I don't tend to interfere too much with how people choose to monitor their weight. I don't encourage people to weigh themselves daily because I don't think it's particularly helpful. Obviously, people's weight depends on, quite a lot of factors. So they're, whether they've eaten, whether they're fasted, whether they're hydrated or not. I mean, you can lose, you or I can easily lose 2 kilos just by dehydrating ourselves. That doesn't reflect any sort of underlying weight loss trend. So I generally encourage people to weigh themselves once a week under reasonably kind of stable conditions. So like pick a day of the week, pick a time, expect there'll be some fluctuation and look at the trend over a period of weeks, not over a period of days.
On the second point in regards to activity, obviously from our perspective, the physical activity is super important for anyone, even if they're not medicated, they're usually losing weight through activity and diet modification. We encourage people to strength train so that they're maintaining a muscle mass, and also the same with the bone density. And I have read some research that the issues with bone density related to taking these drugs can be mitigated with strength training. So obviously that side of things is really important. How compliant do you find people are? I mean, you obviously have this talk with people when they start on the medication that physical activity is really important. How many people actually see it through, and or do they go into it with good intentions, but at a certain point it's like, well, I used to exercise to lose weight, now I'm losing weight and I don't need to exercise. Maybe I can spend my time doing other things.
I think it's very variable. I mean, across the sort of 20 odd years that I've practiced in primary care, every year, I would say, the sort of message that people need to exercise regularly kind of permeates further through the population. Okay. So I think people have much more got that on their agenda. For whatever reason, a lot of people. So I think before people would say, "Oh, I'm just not someone who exercises. It's just not for me, and I don't really think I need to." I don't think anyone says that anymore. Everyone sort of says, I understand the need to exercise. It's just that right now I'm busy because of work, family, other things that are going on. I mean, I think if people are starting on a weight loss treatment, that's a really good sort of point at which they can introduce exercise because, I mean, they're sort of seeing themselves losing weight. They want to optimize their health. They're generally quite motivated at that initial period. And they'll sort of see bigger benefits. So I'm always include a review of people's exercise pattern and advice to maintain exercise or increase exercise load when I'm reviewing people periodically if they're on GLP-1 drugs. And I think, that's probably I think prescribing the drugs without advising on diet and exercise is not really appropriate. So I think that should always be part of the conversation, both at the initiation of therapy and along the way. And some people are sort of slip and have to be reminded, but generally I think people are receiving the message positively. Whether they're actually carrying it through or not is variable.
Yeah. Okay. And are there any other things that you've noticed through prescribing these drugs? And I guess if people are contemplating going down the path with this medication, what sort of advice would you have to offer?
One sort of exciting new thing to say, but first of all, just going back to what I said before about loss of bone density, so osteoporosis, osteopenia. If you look at the very large data sets from when these drugs were prescribed to diabetics who were prescribed GLP-1 drugs did not lose bone density compared to other diabetics. So there's no intrinsic action of the drugs on bone density. It seems to be in people who lose a lot of weight quickly. Right. They're losing weight because they're losing bone density because of the weight loss, because of their nutritional status. It's not a direct effect of the drugs themselves. Right. So if you sort of got a group of people to lose weight abruptly just through calorie restriction, they would lose as much bone density as people who achieved the same weight loss with a GLP-1 drug. So for anyone losing a lot of weight through any mechanism, including like bariatric surgery, for example, bone density is always a consideration.
That's important.
The one other exciting thing, which I think is going to be kind of coming up in the media and in the medical press more and more over the next year, is alcohol. So anecdotally, I mean, I've prescribed Ozempic to overweight and obese people who have a problem with alcohol, and a number of them have reported a significant reduction in an urge to drink. So that's been backed up by some small studies. There are some animal studies where rodents that have been trained to crave alcohol. I don't know how you train a rat to become an alcoholic, and then you treat them with GLP-1 drugs. They consume less alcohol. So it's good news for alcoholic rats in your family. But it seems there is a biological mechanism for this. So when you drink alcohol artificially drops your GLP level, right? So that's why you get hungry and you crave more alcohol after you drink. So if you go out and drink, sort of 2 to 4 units of alcohol, most people who are habituated to alcohol and don't sort of get the Asian blush thing, about an hour later, they'll feel a bit hungry and they'll feel more of an urge to drink. And that's because their GLP-1 level has dropped. So if you give people GLP-1 drugs, they just don't get that. So they'll have one drink and they won't have the same urge to continue drinking. So I've had a couple of problem drinkers who weren't given GLP-1 drug with the intention of reducing their alcohol consumption, who said their alcohol consumption naturally fell as a consequence. So I suspect Ozempic will probably gain a license somewhere as a treatment for alcohol abuse disorder, but it hasn't got that yet. So at the moment we can't. It's not sort of an on-label indication for that yet.
Okay,
but that's coming, I think.
Interesting. Yeah. So I mean, if people are sort of thinking about this, what sort of any particular advice you would give?
Don't regard it as a silver bullet. So it will help you lose weight. You'll lose weight kind of less stressfully because you won't feel hungry the whole time. But you need to think about using a GLP-1 in the context of modifying your lifestyle. So I'd always highly recommend people do a review with a dietitian. I think the reason, or a nutritionist, and the reason for that is, I mean, most of us know that our diet's not optimal and appreciate that we could make a number of changes to improve our diet. I think mostly people try to make a lot of changes all at once. So they're eating an unhealthy diet and they just think, okay, everything's got to change from next week. That's generally not realistic and not sustainable. So if you work with an experienced professional, they will try to get you to make small modifications to your diet serially. So rather than completely overhaul your diet, just gradually modify it over a period of months. And it's much more likely that if you do that, your dietary changes will be sustained. And that means that if you lose weight, then you're more likely to be able to stop using a GLP-1 drug and not have the weight come back on again. So I think, a clear focus on diet and ideally involving, a professional is a very good idea. And definitely being physically active, because, I mean, physical activity alone, people are often disappointed at how they don't lose very much weight. But, I mean, as we've discussed earlier on, it has a clear benefit in helping people improve their body composition as they lose weight. And people who are physically active are much less likely to gain the weight back on again when they complete treatment. So if people can sort of get into the habit of exercising regularly, you're much more optimistic that after however long it takes them to get to target weight, they'll be able to stop using medication and just maintain a new healthy weight.
Terrific. Well, I think that's a good point to end on. Thank you, as always, for sharing your knowledge and experience. And I'm sure we'll circle back and discuss this topic in detail again in another few years.
Yeah, this one will run and run. I think there's still more stuff that's coming out every week.
Yeah. So thanks very much for your time, Tom, and thank you everyone for listening and watching. If you do have some other topics, elements of medicine here in Japan that you would like Dr. Lomax to cover, please let us know, and we'll look forward to having him back on the show.
Thank you very much. Yeah, very pleased to sort of take on new topics if anyone's got suggestions.
Thank you very much.
Thank you very much.
All right, have a great day. Bye.